I'm so glad that you're with us tonight. My name is Kim Porter. I'm the Executive Director of Be a Part of the Conversation. We've been around since 2011. Tonight's program is made possible by some of our favorites here who are with us tonight. We are looking at the Bucks County Opioid Settlement Funds for some funding. Also, though, in regard to that, we have Mallory Parati here from Bucks County Drug and Alcohol Commission. And then we also have funding from the Chester County Department of Drug and Alcohol Services. And you're going to hear from Kathy Collier in just a moment. So our guest tonight, we have Dr. Clay Gueits, and I'll tell you more about him in just a moment. And we've got Tori with us, who is a person in recovery. But first, we're going to hear from Mallory Parati from Bucks County, and then Kathy Collier. And I'm going to stop sharing my screen. Kathy is from Chester County. So Kathy, I'll take over the admitting people into the room. Thanks for the help.
No problem.
Mallory, would you like to start?
Yeah, great. Thanks, Kim. Good evening, everyone. Excited to be here tonight with be a part of the conversation. A big thank you to Kim and her team for putting this event together, and of course for all the work that they do, not only in Bucks, as Kim mentioned, but really across our region. Also, a thank you to Dr. Gueits and Tori. These are two wonderful speakers, so there will be a lot of great information shared tonight. I am here to just talk a little bit about our organization, the Bucks County Drug and Alcohol Commission, and you'll hear from my colleague Kathy, our partners in Chester County, our agencies. There's offices like ours in almost every county in the Commonwealth of Pennsylvania. We're considered the single county authorities or lead drug and alcohol agencies in our respective counties. And what you'll hear tonight from myself, from Kathy, from the presenters, our offices, we are here to help. And we really want to make sure that residents who are in need of resources or accessing services get the help that they need. I just want to highlight a few things in Bucks County. I will be putting our agency website in the chat. Really, if you're a Bucks County resident, encourage you to check our website out. We have a ton of resources and information about how to access services. All of the different resources from prevention, intervention, treatment, and recovery supports that are available in Bucks County. Our agency, like other SCAs, is really here to help fund those in our county who are uninsured or underinsured. But our agencies also provide a lot of other funding for other services in the community, whether that's school-based prevention or recovery supports. Just a few things that may come up throughout the evening, and just something that we want you to remember that our office can help with. We have everything from transportation service assistance in Bucks to recovery housing, several varieties of recovery housing assistance as well. So I will add some links to the chat. And I should also mention that our agency in Bucks can also help anyone access naloxone or Narcan. Of course, it's over the counter and widely available. But if there are any organizations, individuals in need of Narcan, our agency can also be an access point for Narcan as well. I will turn it over to Kathy.
Thank you, Mallory. My name is Kathy Collier, and I am the Prevention Program Manager at the Chester County Department of Drug and Alcohol Services. As Mallory mentioned, there are departments like us throughout the state. We are the single county authority, and what that really means in the simplest terms is we are the entity through which state and federal funds flow in order to support our citizens being able to access drug and alcohol services. And our missions are that we provide the most effective and efficient care so that anyone who is in need of those services, if they are uninsured or underinsured, can still access them, that it not be an impediment to their ability to get to the service that they need. We're very fortunate here in Chester County. We are an incredibly resource-rich county, but if you don't know what those resources are, or you do not know how to access them, or there is some kind of barrier to your access, then you are living in your own personal resource desert. And the goal of our department is to fully hydrate and all those deserts so that they no longer exist. We want to be those oases for every single one of our citizens. And we have a full continuum of services from prevention, intervention, treatment, and recovery supports. Like Mallory mentioned, we also provide transportation. We provide supports to other programs Our particular department is what's called an administrative unit, which means that we don't actually do the direct service. We contract with a network of providers like Be a Part of the Conversation to provide these services. We make sure that we find the experts in the field and all the different aspects of that range and continuum of care to make sure that everything that we are doing can reach every kind of need that possibly can be reached. And we do so with the support of all of our colleagues in the region. You'll see a lot of collaborative programming occur because we recognize that people don't live in a silo. There's not like a wall around Chester County such that if you are a Chester County resident, anything and everything you do happens only within those boundaries. And fortunately, in my time in this work, we are able to say that our funding can go to support anybody who is a resident of Pennsylvania. When I first came into this work, we were only able to support you if you were actually a resident of Chester County, but now we are able to provide that support if you are a resident of Pennsylvania, recognizing that people work in Chester County but live elsewhere, go to school in Chester County but live elsewhere, or live in Chester County but travel to Bucks for their work in their day. And it's so much more collegial and collaborative to not have those boundaries across. So it's really wonderful to be in this time of collaboration and support because we've got a lot of people with a lot of need and they don't necessarily know that we exist. I liken it to the kind of thing where people know that there is such a thing as a car or automobile repair shop, but you don't tend to know where to go and where to turn until you are on the side of the road in need of such a thing. But unfortunately, due to aspects of stigma or shame or just overwhelm, people who face these drug and alcohol issues don't often have the slightest idea where to turn. So our goal in these departments is to say, we're here to help, and we're here to guide you from the moment of recognition of your need for that help to the point of being able to be engaged in that care. So like Mallory, I am going to drop our website into the chat so that you can find some of that information. We have information and resource lines. These are not hotlines, but if you call up and say, hey, this is what I'm facing, you will reach an actual human being on the other side of the line, not a bot, not a computer program. And it is somebody who is trained specifically in Chester County resources and services and how to access them. And with that being said, I don't want to take up too much more of the time. I want to pass it back to Kim so that the program can get started, but I will drop our website and my email into the chat so that you can figure out how to find either me or our services should you need them.
Beautiful. And you two are both just wonderful friends and resources for everybody that we serve. So thank you both for everything that you do and for being with us tonight. I appreciate it. So I'm going to tell you a little bit about our first presenter, Dr. Clay Gueits. Dr. Gueits is an addiction consultation and liaison psychiatrist at St. Luke's Health Network / Penn Foundation in the Lehigh Valley. He is the Associate Program Director of the Addiction Psychiatry Fellowship at St. Luke's. Dr. Gueits graduated from the University of Maryland with a degree in physics. He received his medical degree from Stony Brook University School of Medicine in New York, after which he spent several years conducting neuroimaging research at the University of Pennsylvania. He completed his psychiatry residency at Albert Einstein Medical Center in Philadelphia, where he served as chief resident and developed an interest in treating addictions. He furthered his interest by completing an addiction psychiatry fellowship at the University of Pennsylvania, where he honed his skills in the treatment of substance use disorders. So it's all yours, Dr. Gueits. Thanks for being here.
Thank you so much, Kim. Hi, everybody. I'm very happy to be here. Thank you to Kim and Mallory and Kathy, and Be a Part of the Conversation for having me. This is the third time that I've spoken for Be a Part of the Conversation. I've had a really meaningful experience each time, and everyone's questions have been tremendously engaging and frankly stimulating to kind of trigger me to think about new and changing things in the way that I view addictions and the way that I practice. So I would like to talk about some special considerations, and what I mean by that is, the landscape of addiction is rapidly changing, and frankly, the streets and the substance use that people are engaging in is ahead of where we are from a treatment perspective most of the time, right? Like the climate of, especially the opioid use, on the streets and what's around, changes so rapidly that we've always had to develop treatments kind of in a lagging sense. And over the years, the opioid, for example, of choice changed from opium to morphine to heroin and now fentanyl, right? And so I'm going to be focusing mainly on like how that's changed and the current climate, which is mostly fentanyl and all the problems that come with that. I'm also going to focus on some other substances of use and abuse, including cannabis and some other newer and maybe lesser known substances, but I'll get to that. So I'd like to start by talking about substance use disorder in general. And hold on, just touching. Okay. And the reason I put these numbers up is I think some of them are quite striking. And I think that we don't, when you're kind of putting it into percentages of, America, which has over 300 million people, 11.7%. So that's over 30 million people in the United States use illegal drugs. 20% of those have used illegal drugs or misused prescription drugs in the past year. And if you include alcohol and tobacco, 60% of Americans over the age of 12 have used some kind of substance within the past 30 days. There's 139 million Americans over the age of 12 that drink alcohol, and 10% of those have alcohol use disorder. What I mean by that is a use disorder, by definition, meets a certain set of criteria where someone is, using more than intended, or they develop tolerance, or they're doing things that are harmful while impaired, etc., meeting a certain number of those kind of criteria while using the substance to have a use disorder. 31 million people use illegal drugs, like I mentioned above, and 8 million have a drug use disorder. So meet that criteria for having those problems in their lives and continue to use despite those problems in their lives. So the clinical manifestations of substance use disorder are changes in mood or affect. And so, like I said, they have to meet a certain types of criteria, which is, they continue to use despite feeling depressed, for example, from their substance use. Then there's other types of criteria, such as change in appearance. So that could be anything from how they look, or maybe they are showing up to work or school or home disheveled. But it could also include, that their health is affected, and so thus some obvious change in how they look occurs. Obviously, the third one, physical health, I kind of mentioned above, and then social impairment, which is frankly the last thing to go a lot of the time. So people that, especially high functioning people that have jobs, the job is often the last thing to suffer. So they will let a lot of other things go by the wayside prior to failing at work. And that's an interesting phenomenon that I've seen in a lot of people. And I think the reason for that is at work, it's kind of work becomes part of people's identity, and they're reluctant to relinquish their functioning at work, and it kind of sticks around to last, and they let their relationships, with their family and friends go by the wayside before they let it affect work, which I have found interesting. It's not a rule, but it's something that I've certainly observed across hundreds and thousands of cases. So I want to talk about opioid use disorder, because you probably have all heard about what a big deal is in the United States. It's extremely prevalent. It's the cause of most of the overdose deaths, and it's so rapidly grown compared to use disorders of other substances. So opioid use disorder is defined as chronic use of opioids that causes clinically significant distress or impairment. It's the use of opioids despite social and professional consequences. Examples of types of opioids are, so I say opioid, right? So opioid is anything that stimulates an opioid receptor. That could be innate opiates, things that are made from the poppy plant. So, things like codeine or morphine. But then we have some synthetic ones like oxycodone or fentanyl, which is completely synthetic. To treat these, we typically use things like agonist therapy, which means that it stimulates opioid receptors like those substances or medications, things like buprenorphine, which is the main ingredient in Suboxone, or methadone, which is a long-acting opioid agonist that kind of replaces the job of whatever the other opioids that they were using illicitly is. We can also use antagonist therapy, so that means it blocks the opioid receptor, so that prevents someone from being able to achieve the euphoric or high effects of the opioid that they choose to use, but it also helps with cravings for those substances. And then naltrexone is the one that really helps with the cravings. Naloxone is for overdoses. We also use support and self-help groups like 12-step, smart recovery, and then obviously cognitive behavioral therapy, motivation enhancement therapy, and contingency management, which I'll get into a little bit later in my presentation. Okay. So, my slide is not moving. There we go. So there's over 2.1 million people in the United States have an opioid use disorder, and opioids contribute to over 47,000 deaths in the United States per year. 2 million Americans use prescription opioids, 500,000 use heroin, although I would suspect that number is actually decreasing as fentanyl becomes the predominant opioid. And then deaths to opioid use tend to skew to ages 40 to 50, but overdoses peak between 20 and 30. So more overdoses occur at younger ages, but not necessarily deaths due to opioid use. Okay, so fentanyl is 50 times more potent than heroin and 100 times more potent than morphine. 2 milligrams of fentanyl, which is a small amount that fits on the tip of a pencil, is considered a potentially lethal dose. According to the Center for Disease Control, 107,000 plus Americans died of drug poisoning in 2021, and 2/3 of those deaths involved synthetic opioids like fentanyl. Pretty striking numbers. That's a lot of people and a large percentage of drug poisonings that involved synthetic opioids. That's just synthetic opioids, right? Not even the prescription painkillers, et cetera. Okay, so why is this important? So fentanyl is becoming so prevalent on the street that it's cross-contaminating other supplies of substances. So any powdery substance that people are using, I basically tell my patients that they should carry around naloxone or some version of it in the case of overdose, because any powdery substance, we found a lot of the samples are containing fentanyl in them. So things that can be contaminated, cocaine is kind of the big one that I see in cross contamination with. But marijuana, there's been several case reports across the country, although no deaths to this point in overdoses of marijuana that was cross contaminated with fentanyl. But mainly pills is my concern, to be honest with you, because people press the pills, or they press fentanyl into things that look like pills, that look like OxyContin or oxycodone, Percocet, et cetera. But it's really fentanyl, or maybe it is the substance that they intended mixed with fentanyl, right? So any pill, any powdery substance can contain fentanyl. It's a serious risk. And anyone that engages in these things, I encourage them to consider that they could be using fentanyl, and they should at least educate the people around them, whether it's the people they're using with or family members or whoever, that they carry around the opioid antagonist naloxone that can reverse or stop the overdose process. So the pills are interesting because, like I said, they're designed to be identical to the legitimate pills that are produced in a lab and sold at pharmacies. The DEA in 2018 seized a very large amount of fentanyl laced fake pills that they estimated could kill more than 700,000 Americans just from the batch that they seized. So that's not even counting the ones that they didn't seize, and the ones we don't know about are the ones that are floating around the country. That's just the ones that they found and took, right? So, and then the subsequent laboratory testing in 2021 revealed that 4 out of 10 fentanyl laced fake pills contained a potentially lethal dose. So that's not only did a very large amount of these pills contain fentanyl, but 4 out of 10 contained a lethal dose of fentanyl. And the number of fake pills containing fentanyl has jumped nearly 430% since 2019. So 4 times. Okay, so xylazine. You guys have probably heard of xylazine. Xylazine is an alpha-2 adrenergic receptor agonist. It's a fancy way of saying that it stimulates our sympathetic nervous system, although it happens to stimulate the part of the fight or flight response that diminishes the fight or flight response, so it's a sedative. So we use alpha-2 agonists in medicine. It's an analog of clonidine, as you'll see at the next point on my slide. Clonidine is a medication that we use in opioid withdrawal because it diminishes the physical sensations of withdrawal, so the anxiety and the restlessness that comes with opioid withdrawal. And so it's no surprise that they added this substance to the supply of fentanyl because it makes it more sedating, which is generally what people that are using fentanyl are looking for. The problem is that this medication is not FDA approved in the United States to be used for that effect. It's mostly used in veterinary medicine, and although it acts like clonidine, it has side effects that the clonidine doesn't. In 2021, 90% or more of samples on the street were positive for xylazine in Philadelphia. And when I say 90% of samples from the street, that means 90% of fentanyl samples from the street or or heroin, supposed heroin. But I'll just be honest with you. When I was in fellowship at University of Pennsylvania, we tested everybody that came into our clinic seeking help for opioid use, and we test for the metabolite called 6-monoacetylmorphine, which is a test specifically for heroin. And so few people tested positive for that, even though they believed they were doing heroin, they only tested positive for fentanyl. So when people did test positive for heroin, we actually asked them, hey, like, where did you get this from an epidemiologic standpoint? Like, it was interesting to know where people were actually obtaining real heroin, because, like I said, it's largely been replaced on the street by fentanyl. The reasons for that are largely multifactorial, but mostly it's that you can manufacture fentanyl easily in a lab in the United States instead of having to import heroin made from opium plants from Afghanistan or Mexico. So much cheaper. The supply chains are easier for people that are distributing these to make. Okay. Substances laced with xylazine continued. These numbers are just, I think, interesting because the percent increase is so drastic. The number of xylazine positive overdose deaths by region, in the Northeast, the overdose deaths increased by 103%, containing xylazine when people overdosed. But some areas like the South, it's up, 11x. So very dramatic increases in overdose deaths. And I think there's probably some confounding factors here. Perhaps it's that xylazine is contributing to these overdoses, but perhaps it's just that xylazine is in all the fentanyl supplies and fentanyl use is increasing, and overdose deaths due to fentanyl. It's hard to say, but there's no doubt that xylazine is playing an important role in the street supply of opioids, and it's creating some interesting problems for us because we have to treat basically two use disorders. People are addicted to the xylazine and they're addicted to the fentanyl at the same time. Just some numbers real quick. So the highest xylazine prevalence in opioid overdose deaths by area was observed to be in Philadelphia. That's nationally, right? Second was Maryland, so Baltimore, and then Connecticut, generally like New Haven and Hartford. So illicitly manufactured fentanyls are present in 98.4% of xylazine present overdose deaths. So, that just basically means if someone's using xylazine, it's with fentanyl. Although there were other substances that were linked to the xylazine, like cocaine, benzodiazepines, heroin, and alcohol, but much lower than just with fentanyl. IV users in Philadelphia describe xylazine as a sought-after adulterant because it lengthens the duration of fentanyl injections. So one of the big side effects that I mentioned that xylazine comes with side effects that clonidine, its kind of cousin that works in the same way, doesn't, which is why xylazine is not approved for human use in the United States, is that it causes soft tissue infections, and it also is resistant to naloxone. So if someone overdoses when they're on xylazine, it's harder to reverse the overdose. Like I mentioned, it causes these wounds, and these wounds are particularly troublesome because it's creating more lasting disability in a lot of people that are using opioids. When people were using heroin, I know this is crazy to say, but when people were just using heroin, if they survived long enough to get sober, they didn't necessarily have such lasting disability as long as they were able to maintain sobriety. Now people may achieve sobriety, but a lot of times they're losing limbs during the process of their addiction and are obtaining permanent disabilities. And frankly, once someone obtains a permanent disability like this, a lot of them enter the mindset of, what's the point? Why get sober? I already lost my arm or my leg. And I've had to field these dramatic existential questions from patients that really weren't around before this was happening. It causes these necrotic skin wounds that is not necessarily even related to injecting it. So I think a common misconception is it's only if I inject it, but if you use xylazine at all, whether it's smoked or snorted, it still can cause these wounds, and it's not necessarily even where it's injected, right? So people could be injecting xylazine fentanyl into their arm and getting the wounds on their legs because it's a complicated mechanism that has to do with the vascular supply, the blood supply, to the tissue around the body. So places that have poorer blood supply tend to be affected. So that's like the ends of the limbs, which is feet, hands. Okay, so xylazine dependence. I alluded to this a little bit earlier, but it's difficult to treat because sometimes we treat the opioid withdrawal symptoms and a person still feels like they're withdrawing from opioids because they're withdrawing from the xylazine, which has very similar symptoms of withdrawal. And so a lot of times we use clinically, like if someone's in the hospital admitted being treated for opioid withdrawal or opioid use, we use what's called the COWS scale, the clinical opioid withdrawal scale. But a lot of those criteria will be positive if someone's withdrawing from xylazine as well. So it's hard for us to gauge exactly how much are they withdrawing from opioids because they're withdrawing from xylazine, which creates a very similar clinical picture. So xylazine has a really short half-life, which, drugs with short half-lives tend to have a rapid onset with a very potent effect, and then the effect goes away pretty quickly, which causes this psychological dependence. People then want to use more frequently, and it's leading to people using higher and higher doses of fentanyl and higher doses of xylazine, really just speeding up the addictive and dependence process. Upon induction on Suboxone, so like if someone gets started on treatment for their opioid use disorder, they might still be experiencing withdrawal from the xylazine, which makes it really difficult to get people to stay engaged in treatment, especially if they leave the hospital. The treatment generally involves just supportive care, using other alpha agonists like clonidine, which, as I said, works the same way as xylazine, but without the really severe side effects. Okay, so now I've kind of done my spiel on opioids and xylazine because they're the most prevalent. So I'm going to keep talking about them because they continue to be a problem. But I want to get into stimulant use disorder a little bit because it's extremely prevalent as well. And frankly, it's remained very consistent in terms of the numbers that we're seeing and the percentages. And with the rise of fentanyl, we've seen a rise in dual substance use and dual substance disorder, and frankly, a rise in overdose deaths. So stimulant use disorder includes both illegal and legal stimulants. So that's things that are prescribed for valid conditions like ADHD, but it's also illicit stimulants like methamphetamine, cocaine, and synthetic cathinones, which are known as bath salts. They're not really bath salts. They're things that are made to look like bath salts, but you shouldn't use them in your bath. According to the National Survey on Drug Abuse, 0.7% of people over the age of 12 use methamphetamine. Doesn't sound like a ton of people, but again, in the grand scheme of the United States, 0.7% is still hundreds of thousands of people. And methamphetamine is a notoriously difficult drug to get people to stop using, with really difficult sequelae, consequences to that use. And the reason for that being is methamphetamine stimulates a dopamine release in our reward pathway that is, frankly, on an order of magnitude even greater than fentanyl or any other opioid, including heroin. So, methamphetamine is the most potent drug of abuse that we have. It's really difficult for people to stop using it. 2% of Americans use cocaine. So, if you do the math, that's still, 6 million people, and nearly 1 in 5 drug overdose deaths involve cocaine. So people who only use stimulants have a similar risk of overdose death compared with people who use opioids. And I think that's surprising to some people because I think people think overdoses tend to mostly be opioids, but stimulants can cause overdose too. It looks a little bit different. It's mostly effects on the heart, and not necessarily like an immediate stop breathing and overdose like opioids. So maybe it's not as obvious in the public as opioid overdoses are, but people who use stimulants have the same risk of overdose, which I think is striking. People who use both have more than twice the risk of fatal overdose. So when compared to opioids alone, and so what that means is the two of them together synergistically increase the risk of fatal overdose. So your risk doesn't just add together, it multiplies, right? So the reason for that is probably because each masks the negative effects of the other. So stimulants are masking the respiratory depression that happens when people use opioids, and opioids are masking the excessive activation of the fight or flight and our nervous system that come with stimulants. But when one wears off before the other, you get the overdose, right? So typically it's stimulants when the cocaine wears off, which is a pretty short duration of action, the opioids are still working, and then someone overdoses on opioids because they used more than they would have if they had just used opioids because they feel like they can because of the stimulants. you see the numbers here. More than 3/4 of deaths involving cocaine-involved opioids, more than half of those involving methamphetamine-involved opioids. People are using both of these together a lot of the time. And people who use stimulants have shown poor retention in opioid agonist treatment. So that's things like Suboxone or methadone. But opioid agonist treatment is shown to decrease stimulant use and aid survival. So if we can keep people in treatment with enough time in treatment, we eventually avoid overdose deaths. Okay, so how do we treat this? You treat both, right? So we treat opioid use disorder the same way that I mentioned above, which is medications, therapy, 12-step, engaging people socially. People that have stronger support networks tend to do better in recovery. And then for stimulants, contingency management is one of the only things that we really have good evidence base for. But contingency management is basically you get people to show up to treatment and you reward them in some kind of tangible way, whether it's a voucher program like at the VA where I did fellowship. They give patients vouchers for the store in the VA hospital where they can go and like buy food or souvenirs or whatever. And so that was what they gave out in the contingency management program there. There's also medications that can be used in stimulant disorder like topiramate, which is also called Topamax, and supportive therapy. Okay. Given the increase in prevalence, I want to talk about cannabis a little bit. As I kind of mentioned before, cannabis is, I'm sorry, we were talking before the meeting, so everyone wasn't here, but we were talking about cannabis and why it's so notoriously difficult to treat. And so I think that it's important because it's extremely prevalent. Cannabis is legal in many states. Medical cannabis is legal in our state, Pennsylvania, right? And I have a lot of opinions on the process under which things are selected for medical cannabis and the qualifications. Probably would take a whole meeting to discuss that. But cannabis use is very prevalent, and 10% of all people that use cannabis will develop a moderate to severe use disorder. And that's just a moderate to severe use disorder. That's not even accounting for people that develop a mild use disorder, so with some consequences. But 10% of people, this means 10% of people develop a use disorder where they have 4 or more categories of negative consequences. So that's pretty significant. So that means that 4 or more symptoms, including trouble at work, trouble at home, medical problems, worsening anxiety or depression, using more than they intend, spending more money that they don't have on it. These symptoms are not insignificant. And currently it's very difficult to treat for several reasons. I'm going to focus a little bit more on the medical side of it, but there are societal nuances to it too. So right now we don't have any FDA approved medications for cannabis use disorder. None, right? There's I think some reasons for that, which is mostly my opinions and speculation, but I think largely because people, don't want to stop using cannabis. Society's view of it has largely become that cannabis is fine. And I think evidenced by the policy that most of the country is taking, that legalizing it and making it much more available. And I guess some of that is not for me to say, but we're seeing kind of the negative sequelae of that, which is people that are developing use disorders because of it. But most of my patients that I see as an addiction psychiatrist use cannabis, and most of them don't want to stop using cannabis. So they believe that their opioid use is a problem and they want help with that, but they're not willing to consider that the cannabis could be contributing to some of their symptoms and some of their dysfunction in their lives. We've tried several things in studies. We've researched SSRIs and other antidepressants, anti-anxiety medications, mood stabilizers. None of them have demonstrated significant benefits, right? So maybe anecdotally, some people have experienced some improvement with their cannabis use and the cravings and insomnia, the anxiety that comes with it. But we haven't found it to be broadly generalizable. So we haven't really found anything good yet. Some medications like cannabinoid agonists, so that's medications that kind of work the same way that the cannabis does, but are controlled doses and something that we can actually monitor how much you're getting and take on a regular schedule. Those have shown efficacy in alleviating the withdrawal symptoms, but we don't have anything that's good for preventing relapse or assisting in sustained abstinence. So we can kind of help people through the acute stage of you're having trouble sleeping, you're feeling more anxious, you don't have an appetite. Like you can use an agonist, so a medication that is mimicking the cannabis to help with the withdrawal period, but we don't have anything that keeps people from going back to using cannabis. The most effective treatments that we found so far are motivation enhancement therapy. So that means when we train as addiction psychiatrists, for example, we have really intense training in how to interview people to develop motivations and have them identify things that they're doing and behaviors that they're doing that don't align with the things that they want and their goals. And so motivation enhancement therapy really is having them identify goals that they want and coming to the conclusion themselves that their behaviors and their substance use is not aligned with that. And that takes time, and that takes commitment from a person to engage in that kind of treatment, which I think is kind of a difficult thing with cannabis. Also, again, most people don't want help with their cannabis use. Contingency management, like I mentioned above, which is kind of positively reinforcing those things by giving some kind of tangible reward, vouchers or even money some programs give out. Those can be effective, and the most effective is combining all three: cognitive behavioral therapy, motivation enhancement therapy, and contingency management. In older adults, the agonists have demonstrated some efficacy in relapse prevention and abstinence. So that's only older adults. We're talking over 65. And sorry for anyone that's over 65 that doesn't identify as that. But that's just how it's been classified in the research. But we need more research to be able to really say that this is an effective treatment, and we don't have that yet. Okay, so I just wanted to touch on some other substances because some of you may have heard of these or have questions about them. Obviously, vaping is on the rise. Nicotine, THC, you could vape anything as long as you can suspend it in, an oil that you can put in a vaporizing cartridge or device. You can vape it, and so we're seeing a dramatic rise in that, especially among young people. The accessibility is just so high, and it's really difficult to develop. Again, this is another subset of substances where I think people don't really think it's a problem. They kind of have a lot of built-in excuses. They've been told that it's not as harmful as smoking, and perhaps from a medical standpoint, that is a partial truth, but it's not the whole truth, right? And I think that the perception that it's not harmful may end up causing the same end damage as cigarettes in the first place, just because you're underestimating the effect that it's having on people. Kratom is, I'm going to do a little more detailed on some of these, and Kratom is one of them because Kratom is pretty accessible. You can buy it on the internet. It used to be available at like gas stations and stuff. I think that it's gone from those, but it's pretty easy for people to get. It's an opioid-like medication that causes stimulant effects at low doses and sedative or opioid effects at higher doses. The reason that it's a problem is, again, it's another substance people kind of view as a little bit benign, but it really works the same way as opioids at the doses that people are using it. So we're seeing the same kind of set of dependence. We're seeing this overdoses. We're seeing people come in with psychosis and depression, and we treat it the same way as we treat opioids. And so I see a lot of people that come into the inpatient psychiatric unit, because I'm also a general psychiatrist, that are psychotic from using Kratom. And so the way that we treat is we have to treat their psychosis like any other kind of psychotic episode by using psychotropic medications and antipsychotic medications. But we also have to treat the opioid use disorder, which makes it even more complicated, frankly. Another one that's on the rise is called tianeptine, which is also known as gas station heroin, nicknamed Zaza or Tiana Red. So this is a tricyclic antidepressant. And so we have FDA-approved tricyclic antidepressants in the United States already. Those are things like amitriptyline, nortriptyline. You might have heard people take them for like pain. People take them for depression. People take them for anxiety. But this one is not approved in the United States. And it's because it has a lot of complicated effects in our brains. It works on opioid receptors. It works on serotonin receptors. It works on dopamine receptors. It's kind of we call it in psychiatry like a dirty drug, and what that just means is it indiscriminately stimulates a lot of different systems, and that's a problem because it causes a lot of side effects, and it causes a problem with the opioid agonism because people can overdose on it once again. So it has opioid-like qualities. People can withdraw from it like they would withdraw from an antidepressant, and they withdraw from it like they would withdraw from opioids. So, we really have to keep in mind a lot of different side effects when it comes to this substance, because the toxicity of a tricyclic antidepressant includes cardiotoxicity. So that's arrhythmias. People come in with their heart out of rhythm and have arrhythmias and die from the cardiotoxicity. They can have seizures, and they can overdose on the opioid aspect. They can come in psychotic. It really is causing a whole slew of problems. Thankfully, it's not terribly prevalent yet, but we're starting to hear more and more about it. And then the last thing I'll cover is nitrous oxide. This is not new, but it is kind of it is reemerging as a substance of choice for especially young people. You could literally order nitrous oxide from Amazon and have it delivered to your door and be using it, tonight. And you don't need to be 18 or 21 to order these things if you have like your parents' Amazon account. And so the accessibility is just super high. It's advertised in brightly colored packaging. It comes in many forms. Like I said, it's really easily accessible. But the side effects can be really severe. People can faint, which is what syncope is. They can get heart arrhythmias, seizures, and chronic use can cause cognitive deficits or irreversible dementias in young people, right? And so irreversible brain damage in young people is nothing to joke about. And it could also cause vitamin deficiencies like B12 deficiency, which causes its own form of dementia, but also peripheral neuropathy, making it difficult for people to walk and changes the way that they are able to sense things with their hands and feet. It also causes mood or psychotic episodes, which I think is a theme as I've been running through these slides. That most of these substances can contribute to depression, anxiety, manic episodes in people that are predisposed to bipolar disorder or psychotic episodes. I think I had finished with 3 minutes to spare, which is a record for me. I usually go over. I know I talk really fast, and I'm sorry. I'm not manic. That's just the way that I talk. But I hope that people, if they have any questions, can remember them for after Tori speaks, because I don't want to take away from her time.
Actually, we'll take advantage of that early conclusion there, because we do have a question about. We'll have more questions later, I'm sure. But while it's fresh, have there been any reports of health consequences from vaping, such as lung issues? I think that's a little better, yes, since we kind of
for sure. So I know that many years ago now, I think it was probably like 10 years ago, there were like reports of popcorn lung, right, which is some version of COPD, which involves the breakdown of lung parenchyma. That was related to some additives that were being used in a lot of the flavorings at the time. Flavorings like you're eating it, but the whatever you want to call it. And thankfully, those have generally been removed since then. So, the jury is unfortunately still up. We don't know what the data is going to look like when it comes in, and unfortunately, we're going to need years of people using these things before we know exactly what they're doing. And do we notice improvement in respiratory function tests after people stop vaping? Yes. So to me, that tells me that something is probably going on, just from the irritation that comes from inhaling polyethylene glycol and the medium for the nicotine. Obviously, nicotine is not harmless in and of itself. It's addictive. It's carcinogenic, and again, it's hard for me to talk about because we don't have a ton of data yet. And I don't really like to speak about like my guess as to what will come out about it. But I think this is going to be another substance that is tough for us to combat because of people's perception that it's okay, that it's safe.
Yeah. And we'll talk more about that after we hear from Tori, because I know there were some other questions that came in ahead of time about vaping. So we'll get back to that. But I do want to make sure we get time for Tori. So thanks so much for being with us, Tori. I'm going to let you introduce yourself because we're new friends. And so I'd like for you to jump in and tell us about you.
All right.
Thank you so much for being here.
Can you hear me?
Yes.
Okay, very good. So what's going on? Thank you so much for having me. And thank you everybody who is on for taking the time out of your night to hear a little bit about what we all have to share. My name is Tori. I'm a certified recovery specialist out of Chester County, and I work with ProAct. I was a little nervous about speaking with you tonight. If you know me, you know that I could speak to a wall. I could talk for hours. But when I'm put on the spot, I get a little, so I rather be over prepared than under prepared. So I did write some notes up. When I was asked to tell my story, at first I was like, why me? And the more I thought about it, the more I thought, why not me? I spent a good portion of my life not taking care of my mental health and in active substance use. And I've also accumulated over a decade of recovery time. And I'm also the daughter of somebody who lost their life due to the complications of substance use. So I'm no stranger to mental health, to substance use, and how it can affect families, children, and so forth. A little bit about myself. I am an overcomer. I'm a mom. I am a daughter. I'm a survivor. I'm a partner. I'm also a personal trainer. I'm a nutritionist. I'm an entrepreneur. And I am also a person in long-term recovery, first and foremost. Everything I have earned over the last 11 years is solely because I take it one day at a time. I give my crap to the big guy upstairs. I show up for myself. I put all of my energy into becoming better and running to, as opposed to running from. I grew up in a middle-class family. I had really hardworking parents. I live on a fifth generational farm. My parents were loving. We sat at the table, as families do. We were pretty normal, but we had a lot of secrets and we stuffed a lot under the rug. At the age of 11, I discovered that I could escape my reality. I was in fifth grade when I developed an eating disorder, and it allowed me to escape myself and to not feel. I could take on this new identity, and I struggled with this through middle school and high school. When I was in elementary is when I was introduced to my first set of therapists and had a team. Fast forward, I went to college, and this is when I was introduced to alcohol. And anytime alcohol was involved, so were other substances. I became highly addicted quick, and I did not realize it was addiction. I kept chalking things up to being a college student. My third year of college, my life did become pretty unmanageable. I had been arrested quite a few times for public intoxications and fights. I was working to be able to party, and I had an almost near-death experience, and they found me in a porta potty at Preakness, unresponsive. My parents said it was time to move home, and I came home. And I, again, was doing the therapies, trying to do the meetings, and trying to sober up. I was sneaking substances, and my mind now revolved around getting that next fix because I wanted to escape. I ended up meeting my partner now that summer, and I became pregnant within months, which was a miracle because I was told I could not have children. We moved in together, and he had his struggles too. He had dealt illegal substances, and he ended up getting arrested and going to prison for quite some time. I then was a single parent, hanging on by a bobby pin, attending meetings with my dad, though I was drinking and using on the weekends. Monday through Friday, I was working. I was not working an honest program. During this time, I had gone back and forth with my eating disorders and my substance use. When one would be kind of okay, the other one would be off the chains. Thankfully, I had parents that stepped in and helped with my son. Through these years, I caught some charges. I was arrested. I totaled cars. I landed myself in situations that I don't know how I made it out of. I put myself in dangerous situations, waking up in places I had no idea how I got there, and I experienced a lot of trauma. You know the stories if you know the stories. All I kept thinking about was getting that next fix and blacking out. It was 2011 when I caught a few simple assault charges, and I wanted to unalive myself. I ended up catching a DUI, and I was looking at a lot of time because I had hit someone. I was then gifted the opportunity of mental health court. And in my time ripping and running, I had accumulated quite a few diagnoses and was on a lot of medications, but nothing ever felt right. It just never made sense to me. In mental health court, I had a really great team. I started out going inpatient for my eating disorders for 3 months, followed by a ton of outpatient and working on a lot of things that I had kept hidden for so long. I then attended rehab for a few months, followed by a ton of outpatient. And something, in my journey, I have these points where I have seeds and things that were said to me, to this day made a huge impact on who I am today. And something my son said to me, he was 6 when he came to the one hospital. He said, "Do I have to keep coming to see you at these places with your headaches?" And I'll never forget that, because when he said that, it threw me for one, because I thought he wasn't gonna remember. It was then I realized something needed to change, and I was going to do what I needed to do. I had a really, really great probation officer. I was able to communicate with her. She was strict. She was firm. But I just felt heard when she would talk to me. Like I felt like she had compassion, and that is something that a lot of people do not have throughout my journey. At the end of my mental health court journey, I had a very short relapse with alcohol. So I graduated mental health October 13th, 2013, and I had a short relapse afterwards. And anybody that understands substance use, with each relapse, it gets worse and worse. And I went from 0 to 1,000 in a very short amount of time. And the morning of December 22nd, 2013, my mom had called me and she said to me, "We're tired. We're tired." My family was ready to put me back on the streets, because I had been homeless before, and I was going to lose my son and lose everything. And after that phone call, me being me, I was stubborn, and I was like, "Well, I'm not going to stop." It's not that I didn't want to stop. I just didn't know how to stop at this point. And at this time, my faith was, I don't know if I had faith, but I prayed to whatever it was. And I was like, "Can you just help me?" And I took quite a few shots, and I did whatever I did. And I heard something say to me, like, "Tori, you need to stop." I got violently ill that day. And that was the last time I ever picked up. And I knew from that day forward, something had to change. This time, I ended up getting sober at home, which, by the way, I do not recommend to anybody. It is not smart. And it's not something you should do. I had nobody. I had nothing. My parents and Jason were ready to put me back on the streets. In a couple of the places that I had gone to, some things that really stuck out to me were smart recovery. And I started working a smart recovery program and working on my behaviors, because that made most sense to me. I started leaving the house every single morning with my dad, a lot of silent car rides, and going to work with him. I craved connection, but I didn't know how to connect. I just knew, like, being next to somebody was what I needed. I started journaling everything, my thoughts, my feelings, my urges, my nightmares, things that I had stuffed for years. I started exercising and lifting weights, and this was the sauce for me. This was and still is one of my best tools. Lifting weights has taught me discipline. It's taught me power. It's taught me belief. It's taught me consistency. It's taught me how to show up for myself. It's taught me grit, and it helped me start naming my emotions. I started studying the body, the brain, food, and how to build muscle. My partner bought me a set of dumbbells, and I started doing this all in my garage. I started to learn to love parts of my body that I never loved before. Throughout this, or with this, a lot of my behaviors had started to change too. I knew at the time if I could spend all of this energy and time staying so jacked up for so long, if I could put that towards my recovery and becoming better, I knew I would be a force. The fall of 2017, I found out I was pregnant again. Again, this was a second miracle. I got a new therapist, and I knew from day one that she was it. I felt safe with her. We started many different therapies. We did trauma therapy, DBT, CBT, and I was finally able to speak about my deepest, darkest secrets and started to peel the onion back. I talked about situations I tried to block out. I started to forgive people that did not deserve forgiving, and I learned how to forgive myself. I wish I could say that this is where my story ended. The more I healed, the more I learned about myself, the more I recognized how unwell my dad was. Growing up, my dad was my hero. He was strong, he was determined, he was hardworking, he could do anything. He helped everybody. He was known in our town that you could go to him for anything. And now I know he spent all of his time helping everyone, but he did not help himself. He was no stranger to mental health issues or substance use. He had depression and anxiety, and he was medicated for it. When his medications would run out, he would go to the street, and when they would run out, he would go to alcohol. He went to the best of treatment centers all over the country. He went to the best of therapists, but it was bigger than him. The year before he passed, I knew it was time to put that boundary up, something that was foreign in our family. I could love him from afar and I could show him empathy, but I couldn't fix him. I couldn't help him. I had showed him resources. We had showed him resources. He knew the resources. It was his responsibility. So the months prior to him passing, I saw him very little, just when he would be sober for the few moments he would be. January 31st, my dad lost his life due to the complications of substance use. That was hard. It was hard. I was full of rage and anger, but yet I was also full of guilt because his struggle was over, and I felt guilty that he wasn't here anymore to try. But it was also an unanswered prayer, or an answered prayer that he was no longer suffering. All of these emotions hit at one time, and I knew this was going to be the biggest test of my recovery. I hung on to the thought that I still had to remain doing my things to keep me sober. I had to continue to take it one day at a time, and I was going to use all of my struggles as my strength to persevere. I continued working out. In fact, the night that he passed away, I had to lift. I had to do it. I had to get my emotions out that way. I stayed working with my therapist. I stayed working on my behaviors. I started to be more vocal. I started sharing my story and being proud of it. I was interviewed about my story by a professional for her dissertation, which led me being involved with a nonprofit that brings fitness into rehabilitation centers. By sharing my story, I'm showing hope, humility, and it helps me heal as well by giving back. I started a business helping women who struggle with self-sabotaging behaviors, and I will do whatever it takes to help the next daughter not have to experience what I had to experience. I will leave you with this: no matter which recovery pathway you choose, they all have similar foundations. A few things are always going to remain true with me. Every single day, I show up and I pay my rent towards recovery. I seek God through all of my life choices. I do something very uncomfortable every single day because complacency is no place for anybody, let alone somebody with substance use disorder. I do not use the word never just for today, as cliche as that must be. I work on my shortcomings every single day, my thoughts and my behaviors. I'm constantly working my smart recovery stuff. I exercise and I fuel my body with good quality food because all of that impacts mental health. And I give back to the next one struggling. My experience with my dad is what led me to become or want to become and become a recovery support specialist. One thing I know is that we are more powerful than we give ourselves credit to. People with substance use disorders, they're creative, they're relentless, they're gritty, they're tenacious. We just got to get everyone to direct their energy towards good. And that's my story.
Wow, Tori. First of all, congratulations on your recovery, your beautiful, amazing recovery story. And also very sorry for the loss of your dad. Thank you for sharing all of that. And I really appreciate you bringing up smart recovery. I think that so many people are familiar with 12-step programs like Alcoholics Anonymous and Narcotics Anonymous, but not necessarily smart recovery. Recovery Dharma is something that I participate in. That's another pathway. So I'll ask you to say a little bit more about that. And someone did ask a question. But I just want to say, Dr. Gueits gave us such important information. And what you did was humanize all of that for us, like to really give it like that, because that's what we need both. We need the knowledge, we need the information, we need to know what is happening right now. And you helped us to, you gave us hope and inspiration. I believe, I'll speak for myself, you're very inspiring. And just thank you so much for sharing all of that.
Well, thank you very much for having me. I feel honored and I'm grateful to be part of this, and I'm really grateful to be part of Chester County's PRO-ACT and just keep getting it out there.
Yeah, I agree. Absolutely. So yes, I love that you shared all that you shared. So I have some questions for you, but I would love to hear from our participants, questions for Tori, for Dr. Gueits, for Mallory or Kathy. So please feel free to either put something in the chat or you're welcome to unmute yourself. And as I said, even though this is being recorded, your questions, your image, your voice will not be part of the recording. Okay, we have one for Dr. Gueits. I'm going to read this just in case and everybody can see their chat. From a psychiatrist's point of view, if a patient is heavily vaping THC weed, in a vape pen and takes SSRIs, should the patient refrain from increasing prescription amounts of SSRIs, such as Abilify or Prozac?
So I'm going to refrain from giving medical advice on the group. I will say this, that THC dramatically, it makes our job a lot more difficult when it comes to treating mental health conditions. There's it is at odds with the effects that we're trying to achieve from treatment and medications and therapy. I just as a principle of practice, I don't recommend any dose changes for SSRIs if someone is like using marijuana. I have to pretend that all other things are considered equal, and I monitor symptoms and adjust the dose of those medications accordingly. I recommend to most of my patients that if they have mental health problems that they don't use THC, but obviously that's a personal choice for them, and I'll still work with them to try to achieve their goals through whatever methods I can. And so basically, I adjust the medications according to their symptoms and don't really account for the THC. It doesn't change levels of the medications or anything like that. So I think at worst, it's just negating a lot of the effects that I'm trying to achieve with my medications.
And this is a little bit in line with that. And this was an advanced question. And the question was, our son, 45 years old, has been using cannabis heavily since he was 15, in denial of addiction, has lived in states where it's legal recreationally. His psychiatric hospitalizations have included several dual diagnoses besides severe cannabis use, mostly major depression, most recently for autism spectrum disorder. No backup testing results for us to understand this, since he's never had this diagnosis before. They commented, I assume autism is not a result of cannabis use, but we know that the brain is rewired in addiction, and the prefrontal cortex holds limiting critical and executive thinking, low motivation. How would you begin to treat our son? Obviously, again, you're not here to give medical advice. And then they also ask, how common is this situation? So perhaps if you could talk about
Yeah.
full diagnosis, what you're seeing.
So the situation is very common. For one, THC or marijuana doesn't cause autism. I can confidently say that. Autism is present at an age prior to when anyone is able to use cannabis, unless they're, coming out the womb using cannabis. It's not causing their autism. So there's that piece. But it's very common that people with dual diagnoses or mental health diagnoses use cannabis and don't want to acknowledge the role that cannabis plays in their mental health problems. I see a lot of people that are admitted to the hospital with psychosis or depression or induced manic episodes in the setting of cannabis use. And don't get me wrong, there's a little bit of selection bias there, because I'm only seeing the people that end up in the hospital from doing that. So most people that use cannabis aren't becoming psychotic, right? But the subset of people that do are likely already predisposed to having that effect genetically. We know that there are some genes we've identified that predispose people to having psychotic episodes when they use cannabis, or are predisposed to having schizophrenia, that when they use cannabis, it kind of pulls out those symptoms that they were already predisposed to. It doesn't cause it in someone who didn't have that genetic predisposition, but we know that there are just a subset of people that have more sensitive brains to the effects of cannabis. It's really hard to get them to acknowledge the problem. Like I said, even in someone that doesn't have clear-cut, mental health problems, it's really hard to get people to identify the problems in their life from using cannabis. And even when they do have really clear-cut evidence, like, hey, you've been hospitalized, in a psychiatric unit in the setting of your cannabis use, they're still not willing to acknowledge it. So I think our job is to motivate them to identify when their goals don't line up with their behaviors, and that's really difficult to do, especially as a family member, right? And look, we all have family members with substance use or friends, or our lives are touched in some way, right? And it's really difficult to take a step back. And I'm not saying do nothing necessarily, but these people have to come to the decision on their own. And our job is to detach with love and to support them in whatever way we can, which oftentimes is to maybe sometimes be blunt and say, hey, this is what's going on with you. Like, you should stop. That's fine, right? But also for our own peace of mind, to acknowledge that we can't make them do it. And that's really difficult. And I don't have a good answer for how you could deal with, those feelings of helplessness, because I've experienced it. I experience it every day as a psychiatrist of thinking that my patients should do something for their good and them not doing it, right? I experienced it in my personal life as well. And I don't think it ever gets any easier, but I will say that over time, having that experience over and over and over again has helped speed up the process of acceptance of where does my power and my control lie here, and where does it end?
Mhm. Right. Yeah. And, Tori, you talked a lot about how kind of your initiation into substance use was with alcohol. And then, and please don't feel any pressure to disclose any other drugs that you were using. But I'm just curious. And I wonder too, Dr. Gueits, if you want to comment on this. Alcohol is so pervasive. And it really is. We know that use has increased since the pandemic hit. It's so many more people die from alcohol use disorder than and related things like car accidents and so forth than even opioids and many other really, kind of more immediate mortality resulting drugs than alcohol is. So it's that progression. I feel like it just can take years for it to really become problematic because of the nature of it being so ubiquitous and so accepted, and not just accepted, but validated and shoved down your throats, right? So I wonder if you each could talk a little bit, Tori, for you, like in your recovery. I'm just curious. We've had people on who've said, I used a litany of different drugs and substances, but it was for them, it was cannabis that kept pulling them back in. And they would see the billboards that made it look so helpful and it's medical, right? And all that. And they would start questioning, like, well, maybe I could. And so I've heard people talk about different substances that were particularly challenging for them to stay abstinent from. And then Dr. Gueits, if you can talk about how you see alcohol fit into all of the polysubstance use and so forth.
Go ahead, Joy, you go first.
For me, it was all about, so yes, alcohol was my first, but anytime I would drink, I would go to pills and some other powders. And I knew I could stay away from that if I could stay away from alcohol. And it was all about, in the very beginning, it was all about doing the exact opposite of everything I had been doing previously. Like, I craved connection, but I isolated. So I started being around people. I started going with my dad everywhere because he had his own business, so it was easy for me to be with him. I started forcing myself to have conversations, forcing myself to exercise and pay attention to what I was sticking in my body, because I wasn't doing that for so long. So anything that I was doing that was not helpful, I did the opposite at first. And I kept telling myself, like, I can't have a drink. I have an allergy to alcohol. And it just became easier after my last experience. It became easier for me to just say no. And it might sound cheesy, but it just was. And the people and the places in the very beginning of my recovery, there were a lot of triggers, I guess you could call them. And I stayed away from them until I could work through them. And I did that with my therapist.
Great. Thank you. Thanks for that.
Yeah, alcohol is insidious. It's so ingrained in our culture. It's not like, opioids, right? Like I could tell people, like, okay, stay away from Kensington, and if they truly want to stay sober, they could do that. Then they might not encounter opioids in another setting, right? But alcohol is not something that's avoidable, and so I think the problem with alcohol that I see is that it just takes longer for most people to receive the negative consequences that it takes to hit bottom and to see the need for change in their life. And so a lot of times that happens when people are advanced in age, and the problem with that is because by then you've developed decades of habits instead of years of habits, right? And I think getting someone to change their lifestyle they've lived for the last 40 years is a lot more difficult than getting a 26-year-old who's been using opioids for 10 years to stop using opioids. I just think that the lifestyle changes is much more difficult for a lot of those people. Not to mention they've been able to generally live somewhat successful lives to a lot of degrees, relationships, marriages, children, work, whatever. Alcohol takes longer to take those things away from people. A lot of the time, not always, right? Like, I obviously know people that got sober from alcohol at 21 or 18, right? And so it doesn't discriminate, but I will say generally the bell curve is very split from like alcohol being much older patient population when people recognize it as a problem and get sober, and that versus like opioids and stimulants, which is much younger cohort. And so, having people overhaul their entire life and friend group at age 60, 50, 60, 70 is a lot harder. It's harder to make new friends. It's really harder to develop that social support. I think that's why 12-step programs or whatever recovery programs are super important for especially the older demographic, because that's just an instant connection and plug into a group of people that will do anything for people. And I think that's really important. So I think no one has a monopoly on recovery. And look, I've had patients decide, hey, I want to be sober from opioids, but not alcohol. And most of the time that doesn't end up well because our limbic systems, once hijacked, never go back to normal. But there's exceptions to every rule. I have seen people do it successfully, but it's the exception, not the norm, right? And I'm open-minded enough to accept that, like, it's your life and your recovery. It's not for me to say what it looks like. I'm here to help you meet your goals. If you want to try drinking, I'm going to counsel you not to do it. But like I said, I've seen people do it and do it successfully, but it's the rarity.
Yeah, just a little side note. My dad is 93 and he got sober at 66.
Wow,
And it was a pure alcohol. So
amazing.
it is possible. It is possible. It was tough though. Yeah, totally. He moved to another state. I mean, he changed his life completely. So yeah, it is possible. Thank God for that. So, Dr. Gates, we have one for you. Recently, we have seen a rise in ketamine use. Have you been seeing this rise? And do you have any information on this trend?
Yeah. I think this is a drug of public perception. You know, ketamine has been around a while. We use it. I'm a former anesthesiologist. Take that for what it's worth. And we use ketamine a lot in anesthesiology, right? And so it's a medication that's not new. It's been used and abused for a long time. But recently, with the talk of this being used for mental health treatment and it being used for mental health treatment, right? It's FDA approved for serious major depressive disorder that's refractory to other medications. So it has legitimate medical use. But people kind of take those ideas and run with it. They're like, ketamine's used for mental health, like it must be good for me, right? But then they're using it in a non-controlled and abusive way. So I think it's we have seen a rise with it. It in most people, it's not going to cause tremendous negative effects that what end up seeing me, right? I see the people that end up on my psychiatric unit psychotic from using ketamine and the dissociative effects. So it is a rising problem. I think for us, the battle is really going to be, encouraging people to look at the data and the evidence of like how this should actually be used. It should be used with a medical professional, not like you getting it from your buddy at the Fish concert.
I got that. Okay. Tori, a couple things for you. One, and we're kind of running short on time. So if you could talk just a little bit about smart recovery, and I can put the info, I put it into the person who asked the question, but I'll send it out to everybody. So we can talk about that. And also you have a lovely comment in there from someone. So we can check that out on your, yeah. But go ahead, tell us a little bit about smart recovery and how that worked for you.
Smart recovery works a lot on behaviors and goal setting and the specifics of, what are you after? What behaviors do you want to change? How are you going to replace those behaviors? And then putting them into practice. I am somebody who learns really well, and from writing stuff down and being accountable to what I write down, and just following through on behavior change and setting the goals and being specific and continuing after it. There are smart recovery meetings online and in person that people can go to. There are workbooks out there, smart recovery workbooks. Like I said, there's lots of sheets, on creating goals. What's it going to take to get there? What behaviors are in your way that's, not letting you get there? And how are we going to change that? And that just made sense to me. And I want to say this real quick before I stop talking. When it comes to recovery, you got to find what makes sense to you. You got to find something that is, you can stick it out with and you can do. There are a lot of recovery pathways that I have tried in the past, and it just didn't make sense to me in the very beginning, right? Now I've kind of, tapped my feet in a couple other pathways, but this just made sense to me because I was able to identify how bad my behaviors were and what needed to change. And one of the biggest behaviors I started with was lifting, and it just kept me going. So now I'll stop talking.
Thank you. And here's just a giant question. And the question is, do you have any tips for parents? I think this is for any of us. I welcome Mallory and Kathy into the conversation too. Any tips for parents of young adults who are using THC and other addictions? And I'll just quickly give a plug for, yes, parents, please connect with our support services, such as our parent partnership meetings. We have, of those 21 meetings every week, 3 of them that are on Zoom are for parents of adolescents and young adults. So specific to that population. But, we have loads and loads of resources, but I'll let you all chime in on.
I think Kim is more qualified to answer this question than I am. So.
Well, I have a son who was in love with THC, and his recovery began almost 15 years ago. So it was not even remotely what's being used today. Concentrates weren't even around then, and that's obviously a huge challenge. But I would hope this person, I'm going to put my contact info in the chat. I'm always happy to talk to family members. Tori's is peer specialist with people who are seeking recovery or in recovery. I'm a peer specialist for family members who are affected by someone's substance use. And so I will put my contact info in there. But there's all kinds of, there are things like motivational interviewing. We can talk about interventions. You've heard it multiple times tonight. Cannabis is challenging, where there is not a lot of motivation to change. And so there are some ways to get creative around that. But it is, I feel you. It's tough. It's really
And look, I think that Tori said something that was so true, and it just like really rings true for all of addiction treatment, which is, plant seeds, right? Like you can't make someone be ready to be sober and recovery or stop doing what they're doing. You can't. It's impossible. Like they have to be ready. And sometimes they might agree with you when you say they need to, and they'll rebel against you anyway, because that's the personality part that comes with substance use disorder. And so when they're ready, they'll remember all those things that you said. Our job is to support them and to plant those seeds until they reach that point. And unfortunately, like we don't know how to make people reach that point faster. I think that the harder we dig in, the harder they dig in, and just from experience, people just are not going to change until they want to do it, and until it's their idea, and until they've had enough. That when the pain is great enough, they will stop.
Yeah, and we do not need to wait for them to hit some kind of bottom, though. Even though they need to be the ones ultimately to carry it forward. We can put some things in place that raise that bottom for them. And I know I hit my bottom in that my son had no intention of stopping using when he was 21 years old. Absolutely no intention. He thought life was just grand. Because guess what? We were supporting him. He was living with us. Life was good, comfortable. He was making, just enough money to cover his drug habit. And we were like, okay, we're finished with this scenario. He wasn't, but we were. So we can do some things to put that in place. But it was him. He was the one who had to then invest in his recovery. And he's been to one treatment center and he's got almost 15 years. So that's possible too.
Amazing.
And I know we hear lots of stories that are very scary about, 10, 20 more treatment experiences. And that's also common, unfortunately. But it doesn't have to be. So lots of things we can do. And we're very lucky that we're connected to so many resources, like our counties, like lots of treatment specialists, like Dr. Gueits and others. But I'll invite Kathy, Mallory, anybody else who wants to chime in.
I mean, the only thing that I would want to chime in and say to add to the don't wait for him to hit bottom answer is, don't forget to work on yourself and your own education and your own understanding and your own ability to stand in your own issues and truth and work through them, because sometimes your loved one just isn't going to be ready to get help. And that doesn't mean that you can't, and that you can't find support and you can't find ways to interact more skillfully with that person. Sometimes people think that person has to go into their treatment and their recovery first. Like, it's that old airplane adage, put your own oxygen mask on, take care of yourself, make sure you're okay, because you certainly won't be doing them any good if you aren't solid.
So glad you said that. Thank you, Kathy, for that. Yes, take our family recovery course. It's about you. That course is not to find ways to, that everybody who signs up for that, not everybody, a lot of people who sign up for that course, when they're asked, what do you hope to gain from this course? It's like, I want to get my kids sober. That's not the point of the course. The course is to help you understand this, to get your feet under you, to recognize the trauma that we've experienced. When we watch our child go through this, that is traumatizing. We have parents who have administered Narcan to their child. How do you hold a boundary once you've done that? So we're here for you and want to support you. So I appreciate that, Kathy. Very well said. Just thank you all. This was wonderful. You've been all just so interesting and terrific. And I just thank you very, very much for all being with us. And keep up the good work, everybody.
Thank
Thank
you
you,
all.
Kim.
Yeah,
Be
thank
well.
you.